Our next speaker, Dr. Jyoti is here. Yeah. She'll be telling about prescribing glasses in children. What is the right way? Over to you, ma'am.
Hello everyone, I would be presenting on prescribing glasses in children was the right way. I think most of the golden points has already told. So objectives of my talk would be what are the age appropriate vision assessment methods, how we would go for cycloplegic refraction, a little bit of understanding about emetropization, and what are the different guidelines for prescribing in myopia, hyperopia, astigmatism, anisometropia, and other special situations if time permits. So there are certain factors that we need to consider before prescribing. First is visual needs according to age of the child. How do we understand this? See, the for an infant or for a kid of around 1 or 2 months, the kid would be more interested in near world. He would be more interested in seeing the mother's face. So prescribing a -3 diopter to a 1.5 month old kid would behave differently to the same prescription that we give to a 12-year-old child, right? Then the second component we have to remember is all kids will have a very strong accommodative element, so that would mask certain types of refractive error, and by the time the kid presents to us, the child would have already landed up into amblyopia. The third point is we have to look for whether the child has a squint or not before we prescribe, because when I practice, I have this mindset that first thing I need to do is I have to rule out strabismus, because if the child has squint, I would make certain modifications to my final prescription. Another thing is age-related emetropization. We would learn about it a little later. And then the risk of amblyopia, because whatever prescription you give to a kid, you have to make sure that you are mitigating the risk of amblyopia. And then we should also take a systemic history of the child, whether he has Down syndrome or some developmental delay, because such kids will have accommodative lag. So accordingly, we need to prescribe. Coming on to age appropriate vision assessment, why the visual acuity measurement has to be age appropriate? Because children are in a phase where the eyes are growing, they are growing. So the visual acuity methods you are implementing has to be according to the age of the child that he or she is presenting with. Whenever a kid comes, we have to try to give them a comfortable position, and of course the mother's lap is the best position for a kid to relax and for an examiner to examine. So when the child is relaxed, you can do the baseline examination, torchlight examination, and if the child has squint, you can also do a cover uncover. By that time, parallelly, you can take a history, ocular history, systemic history, everything, and then you can design the strategy how you need to proceed further. So another thing is you always divide the patient into, you categorize the patient, whether the patient is infant, toddler, preschooler or school going, and accordingly there are a battery of tests available for measuring the visual acuity. For infants, we need to look for the fixation, whether it is central steady maintained or not. Optokinetic nystagmus drum is another technique with which we can assess whether the child has a good vision or not. See, the quantitative assessment of vision in infants is not possible as such. So whatever methods we are implementing is to assure that whether the child has vision or not, the child's visual pathway is functional or not, whether the afferent or efferent pathways are functional or not. For toddlers, I most of the times prefer Cardiff acuity test. Then for preschoolers, Leah symbol, K pictures are more popular. And as the child grows and they have little bit of understanding and comprehension, you can always go for Snellen's visual acuity test or Logmar chart. Logmar chart is more repeatable and preferable. Coming on to cycloplegic refraction, so a good retinoscopy is a gold standard. A good retinoscopy is a must, and atropine 1% is the gold standard cycloplegic. So preferably, in our center we do CTC. We most of the times do CTC protocol where we put 1 drop of cyclopentolate followed by 5 minutes के बाद में tropicacil, and then again after 5 minutes you put cyclomide and do a refraction of after 60 minutes or so. So the idea behind doing a CTC is the child need not come back again, and the effect would be lasting for 24 hours. So if the kid has some exam or some test to go, the child can always go. But if the only side effect with cyclopentolate is it causes certain neurological problems. So if the baby has history of seizures or developmental delay, one can always switch to homide eye drop. Another option for doing auto-refraction in kids is photo screeners, and we can, while performing retinoscopy, we can also use this skioscopy racks or retinoscopy racks, and they are very good for performing retinoscopy, because most of the times the child will not allow to put a trial frame over their eyes. Coming on to emetropization, so the basic three refractive components of the eye is cornea, lens, and the axial length. So emetropization is the process by which a normal eye has a coordinated growth of its refractive components during early childhood, and that would allow the eye to reach to near plano. And at birth, as Sir said, most of the infants would be hyperope of around +2 diopter, and they will have certain amount of astigmatism also. Until 2 years for hyperope, then this would be followed by a slower phase of emetropization, and until 2 years for the emetropization will go for 2 years for hyperope and 4 to 5 years for myopes. The rate of emetropization is considered proportional to the initial error, and it is usually completed by 6 to 7 years of age, and thereby myopic shift sets in. So these are the basic refractive components of the eye: the curvature of the cornea, the curvature of the lens, and the axial length. Coming on to the guidelines for prescribing, so we have different guidelines, the AO, APOS guidelines, and we have the AIOS guidelines as well. So the guidelines basically provide us with a framework or a foundation, but the actual prescription depends on your own clinical judgment and experiences. So as we look into this AO guidelines, we can see that the threshold for anisometropia is lower than the threshold for isometropia. Like for a child of 3 to 4 years of, for a child of some 1 to 2 years, less than 2 years of age, myopic child, you need to prescribe if it is isometropia of more than 4. But the same kid, if the child has anisometropia, one has to prescribe if it is 3 or more. So the threshold is lower when it comes to anisometropia, because it is the most common type of anisometropia can lead to amblyopia. Another thing is AIOS guidelines. These have been developed to address the local variation in the pediatric refractive error, and I personally find them more suitable, because when I deal with Indian population, I find them more suitable. So coming on to hyperopia, the first thing we need to see in a hyperopic patient kid is whether the alignment is ortho or not. If the child's eye are straight, I usually go for mild undercorrection to allow some emetropization to occur. And if the child has esotropia, I try to prescribe full plus, always give full plus, and allow them to come after 6 to 8 weeks for a follow-up. In follow-up visit, again, if the child has less than 8 to 10 diopter, less than 8 to 10% diopters of ET for near and far, then we are sure that it is a refractive accommodative esotropia, and we can continue with the same glasses. And remember that if it is refractive accommodative ET, we need to prescribe full plus. And if the child on follow-up has more than 8 to 10% diopters for near and far, it means he has partially accommodative ET. So we have to plan surgery for the remaining amount of esotropia. And suppose the child has less than 8 prism diopters of esotropia for distance, but more than 10 prism diopters for near, then it is a non-refractive accommodative ET with high AC by A ratio. In such patients, you have to consider for executive bifocals bisecting the pupil. Always give full cycloplegic correction in hyperopia with ET. So when I say executive bifocals bisecting the pupil means that would be something that would encourage the use of near component. It has to be flat topped, and gradually the idea is to gradually reduce the power to increase the divergence amplitude. And with every visit you have to keep the patient on close follow up, and as the child grows, the bifocal power you need to reduce gradually. Coming on to myopia, so for more than 3 years, more than 4-year old kid or preschooler, you prescribe if it is more than 1.5 diopter or if it is if the child is presenting with symptoms. The aim is to prescribe the lowest minus power needed for the best visual acuity. In a broad outline, myopia more than 3 years of age, -1 to -10, it is pretty straightforward. You need to give full correction. And coming on to astigmatism. For preschooler more than 4 years of age, prescribe if it is more than 1.5 diopter. In astigmatism, there is some confusion whether to prescribe full or keep them under correct. The general
Doctor, yeah, just
yes, ma'am.
yeah, you can just sum up and
Okay, so the key points are: categorize the kid first as per age, then employ age-appropriate visual acuity methods, do a cycloplegic refraction which is must, rule out squint before prescribing, and consider the role of hematropization and risk of amblyopia. Thank you.
Thank you for a very good talk. Just wanted to know, how do you ven up the patients, those who are having a ACA ratio, and you are giving them the bifocals?
Sorry, ma'am.
You are giving them the bifocals in those cases where you are having a AC by A ratio, high AC by A ratio. So what time, how frequently you call them, and when do you ven the glasses for these cases?
Ma'am, patients with high AC by A ratio, I basically work in a medical college, so I have only 2 or 3 kids to whom I have prescribed executive bifocals. If I call them to come after 6 weeks or so, they won't be coming. So most of my follow-up patients would come after 6 months or 1 year, or some of them would be lost. So, but the routine protocol I follow is to ask them to come after 6 weeks or so.
thank you.
Thank you.